Archiving started.
Good morning. This is Linda Floyd, and I'm going to record this session. Just to point out some things, if you haven't used Wimba Classroom before, there is a talk button. It's at the near the bottom left-hand side, and you need to press it while you speak and hold it down, or you can type, as some of y'all have done, into the little text box at the bottom. Now, underneath our names, there, where you're in the middle of the screen, you should see some little emoticons down there at the bottom. And for those of y'all who are here, if you would, just go ahead and select that hand. That's the symbol for a raised hand, just to let me know that you can hear me. And James, can you hear me? Okay, it's sort of the bottom center of my screen, right near the frame. There we go. Good. Okay, thank you. All right. Okay, now you can click it off. Click it one more time. See if that'll remove it. I think that'll remove it if you click it. There we go. Super. Okay, we'll go ahead and get started. And you can raise your hand if you have a question. Use that little emoticon. If you need to adjust the sound, just adjust the volume on your computer. And like I said, you can either use the talk button and speak to us if you have a microphone on the computer. If you do not, you always have the option of typing a question out in the text box where we typed good morning. Now, I can tell you Kaplan really followed the content, the way it's presented in Townsend, pretty closely. And the most important point that I can make for y'all this morning is to approach this test by pacing yourself, and you want to achieve a balance between reading the question very carefully and reading the whole question before you start to think about the answer. You should read that whole question to make sure you're not misreading any key words. And because I think there's frequently that bit of anxiety that all of us have with test taking, I believe. And sometimes we'll read something, we'll recognize a term, it'll be something that we've looked at, and our mind leaps ahead and makes assumptions about what the question is about, and we fail to read the whole question carefully. So I want to caution you that I believe that was one of the most important things on this test, is achieving that balance between taking the time to read that whole question carefully before you start thinking about what the answer is. And then, balancing that with pacing yourself, because you do have 90 minutes to do 75 items in. So you have, you need to be, finishing an item in about a minute to give yourself that, so that you won't be rushed there at the end. So I think that was key for me as I was taking it, because I started noticing there were a couple of items where I had overlooked some words or misread them. I had read unexpected as expected. So it was just a time waster, because then when I started looking at the options I had for answers, they weren't making sense to me. So So I had to go back and read the question again. That is also, I believe I mentioned in class that there are lots of items where they'll have 3 correct answers, and you pick the one that doesn't fit, the one that is not accurate. There were lots of those. But we'll work through the content in the Kaplan Review book, so you'll need to have that with you. And I'd have some paper and pencil, and I want to, hang on just a minute, someone's trying to get into the review. Let me respond to them. Okay, I sent them a text. My apology for the interruption. So let's get started with Kaplan. As we work our way through this content, please feel free to raise your hand and ask the question. But we're going to start in the Kaplan Basics book on page 513. This first section that is in the chapter Basic Concepts looks at really elements of the mental status exam. So I want you to take what you've read in your study in Townsend, take that along with the observations you've made in clinical this term, either at Greenleaf or Northside. And I want you to think about, your observations of the person's psychosocial well-being. You can think of this in terms of what is a normal, healthy standard. Someone who is functioning in a very adaptive way that meets social norms versus many of the patients you observe in the clinical setting who are in some mental health crisis, who, if you did mental status exam on them, you would pick up abnormalities in these areas. So we look at, and they will, sometimes on the test, they'll describe for you the person's appearance or the speech that they're demonstrating, or some evidence of disorientation for the sensorium. Now, Kaplan only mentions on page 513 under sensorium, item number 3, they only mention orientation to person, place, time. Sometimes some sources include situation as a 4th sphere of orientation, but the only ones you need to be concerned about for Kaplan is going to be person, place, and time. But just take a look at that and compare that content that you see in Kaplan with what your own observations have been with real patients. If you look at item number 5, what were the family relationships and the work habits like of the individuals you interacted with in the clinical setting? I imagine just in your informal one-to-one interaction, you could collect data that was evidence of some kind of interpersonal conflict, or someone's inability to trust, or ways that they were maladaptive ways that they were coping with stress, or how they were overwhelmed and overstimulated by things that were going on in their environment. So this initial content in Kaplan really looks at, normal mental status functioning versus the abnormal that you've been able to observe in the behaviors in the clinical setting.
Can you hear me?
I do. Who is that?
This is Louis Freeman.
Hey, Louis. Welcome.
Is everyone
Can
dialed
you
in?
hear
I tried to
me?
go. Yes, I can hear you. I tried to go in online and could not log into the web page
Oh.
because there was a login that said you needed a login name. I'm actually dialed in.
I see a telephone number up there. Well, you really just you couldn't get into the course.
When I hit the course button to join, it said I needed a log on the username. Right. I don't know what.
Okay, now, did you actually get inside the course? Because your logon username is just your Active Directory logon and password.
I'll try that. I did try
Okay.
that. It still
It
kicked
didn't
back
work?
to it. It's okay. I can listen.
Okay.
And I'll keep my mouth shut so you can continue.
Well, if you have any questions, let us know. But we're on page 513 in the Kaplan Basic books. Moving on to this next component looks at the history that you as the nurse gather from that initial assessment you do with the patient. And in this section, we're trying to assess whether or not the person has adequate supports, and that by supports, those can be internal, strengths that the person has, their successful ways of coping in the past, or it can be external. It can be support through loved ones, through their church members, those kinds of things. So sometimes we think of this in terms of, what are the strengths and the weaknesses that we can evaluate for this individual? What are their, do these items that are listed here under history, community, family, their economic situation, their level of education, are those things support systems that they can go to in times of stress and crisis? Or do these things actually represent stressors in their life? Are these, and that can mean that this is a weakness, that the person doesn't have a stable home to live in, they don't have a job to earn income, they lack formal education, those sorts of things. So we're assessing at this point, we're doing our initial assessment with the patient, and we're getting a sense of their internal strengths and weaknesses and their external support systems or stressors in their life. As we move on to the very bottom of that page, Kaplan talks about some of the risk factors that we can identify in the assessment stage. And some of those things, certainly a very profound risk factor for mental illness is a family history of mental illness, because we know many of these illnesses we've looked at this term have that strong heritable component or familial pattern. And if someone in the family has schizophrenia or a bipolar disorder, then their children, their first-degree relatives, have a much increased risk of developing some mental illness. It may not be the same diagnosis. If it's a mood disorder, it may more likely be one of the mood disorders. If it's an anxiety disorder, it may more likely be one of the anxiety disorders. Another potential risk factor that we should be assessing for is our patient's medical history. And I want you to remember that there are dozens and dozens and probably actually hundreds of chemical imbalances, metabolic imbalances, medical conditions that can be diagnosed that produce psychiatric symptoms. And when we look at the DSM diagnostic criteria, at the end of every chapter in the DSM, they will have the option of diagnosing that person with their mental illness being the direct consequence of some medical condition. So that's always an option. And we need to make sure, if that person has a mental illness that's a direct consequence of a medical condition, then we need to diagnose and treat that medical condition to relieve the psychiatric symptoms. And the final risk factor is more of an environmental factor, and that deals with, what stressors or resources the person has in terms of support or lack of support. All right, let's move on. Any questions about that first basic concepts section where they're pulling in elements of the mental status exam and they're looking at how you as the nurse assess the patient on your initial contact with them? Okay, we'll move on to the theorist. This is on page 514 in Kaplan, and they're pretty basic, which is great. We don't have to get into this into too much depth. But if you look at the top of page 514, there's some very familiar content there. You do need to have a very clear definition of how Freud defined the id, the ego, and the superego. And, these are what were called structural elements of the personality that Freud described. And, he could not locate a place in the brain where these resided, but he said these explained human behavior. And these were responsible for personality development. And so be very clear that, we come into the world with the id. That's what we're born with. It is unconscious. When they say it's immediate, we have this strong drive to satisfy id impulses. And those are those appetites for things like food, sex, aggression that follow what is called the pleasure principle. And the id knows no rules, follows no rules. It's just, I want it, give it to me now. And that's what we come into the world with. A little later, the superego actually can be, and it's important to note here the way Kaplan describes it, it cannot just be unconscious like the id. It also has a conscious element because it's the rules that our primary caregivers instill in us. It's what they role model. It's the values that we incorporate. It does tend to be rigid. It can be very punitive or punishing, and it's the basis of where our guilt and shame develop. And if you think of the id that we talked about first as the child, the superego would be the parent, and then finally the ego will develop as a balancing element. It's called the reality principle. It is conscious, and it negotiates between the id and the superego. It is the adult element of the personality. It follows what's called a survival principle. So it helps to try to achieve a healthy balance between the id impulses and the superego rules and restrictions and rigidity so that the person can function as a healthy adult. So you need to have a clear understanding of those elements described by Freud, And if we move into the chart, they look initially at stages of development for Erikson, Freud, and Piaget. You don't need to go into a lot of depth, fortunately, in terms of what Kaplan expects of you, but you need to know the sequence of the Erikson stages of psychosocial development across the lifespan. And we've talked about these in class, that they develop in a stepwise fashion, that there's going to be a critical period of development where a particular task needs to be mastered for the person to successfully go on to the next stage of development and work on mastering the next task for that stage. And these skills build upon one another across the lifespan. So take a little bit of time to review these. You may have a good solid understanding of what they are, but you don't have to memorize exact ages, but you do need to have the general idea that trust versus mistrust is a task to be mastered in that infancy period, and that's mastered by the infant being provided with a consistent nurturing caregiver. Then, in the toddler years, autonomy. In the preschool years, initiative. In the early school years, industry, academic achievement, those sorts of things. In the adolescence, forming a sense of identity, what your place is in the world. And in early adulthood, intimacy can be forming a relationship with a partner, or it can be devoting your life to some avocation. Middle years, generativity is going to be where you have achieved a sense of skill in life, and you're concerned about the generations that are going to follow you, so you want to share your knowledge and your skill with others. And then finally, in the final stage there, in the older adult years, integrity, where we review what our life has meant, what life goals we've met or not met. And think in terms of the population that you've worked with this term in the clinical area. If the person did not master the particular task at the particular critical period, according to Erikson, then there will be some lasting negative outcome. And we should be able to observe their struggle in life and the types of problems they're having as related to that skill that was not mastered at that critical period. That might mean mistrust. It might mean dependency or a lot of shame and guilt. It might be a sense of inferiority, confusion about their place in the world. It could be isolation. It could be that stagnation, and that by stagnation, or they also refer to that as self-absorption, where you lack any empathy towards others. And finally, a negative lasting outcome could be despair, where you realize life goals have not been met and there's no opportunity to meet those goals. So think about the normal, healthy functioning first, and then think of examples that you've observed of how people have negative lasting outcomes when they don't achieve these skills. I don't think there's anything specific that you need to know about the Freudian stages. In terms of Piaget looked more at cognitive functioning, and if you look at those stages on page 514, you'll see that the child in the sensory motor stage is exploring their environment. They're putting everything in their mouth during that sensory motor period. Pre-operational, they're still your very concrete thinkers all the way up to they start thinking hypothetically when they achieve at about age 12. So I would just go back and if you have difficulty remembering those Piaget stages, I think there's a little bit more detail. Let's see, where is Piaget? Erickson is in Townsend on page 39, and that gives you some examples. Okay, Piaget. Piaget is on page 43, and they give you a little bit more detail of, what the developmental tasks are at the sensory motor, the pre-operational, the concrete operations, and the formal operation. So I'd refer back to page 43 to get some good examples. Okay, moving on to the top of page 515. That's just a review of what we've already talked about. Erickson, each stage in Erickson's psychosocial development across the lifespan represents some significant developmental milestone that should occur or be mastered at a particular critical period. And item number 2 says completion of one stage is necessary for the next stage. That represents that stepwise fashion that we talked about, where the skills build upon one another. Harry Stack Sullivan is the only other theorist that we haven't mentioned so far this morning, and his focus, where Freud's focus was on more the internal intrapsychic anxiety that occurs in human beings, Freud took those principles and branched out and applied them to interpersonal relationships. So that was his focus. And I think it's important to note that the most famous psychiatric nurse, Hildegard Peplau, was a student of Sullivan's, and she took Sullivan's interpersonal relationships model and applied it to the nurse-patient relationship. Now, Maslow is mentioned here. I did not include a illustration of Maslow's hierarchy of needs, but you have it there laid out for you. And I think it will be extremely helpful to you as you're answering questions if you keep that hierarchy of human needs in the back of your mind. It's that little pyramid where you have the basic physical needs at the base of the pyramid, and you work your way up to self-actualization at the tip of the pyramid. And you see the order that those go in listed here on page 515. That start with the physical, proceed to safety, then love, then self-esteem, self-actualization. Now, this is going to be helpful to you in prioritizing. Okay? And I know that there's been a little bit of confusion, I think, recently among some members of the class about how to decide what has priority. And a couple of things I'd like to say about that is always prioritize according to what has the most life-threatening potential. And another way to think about that is that some conditions are acute and others are chronic. If I have something, let's say I'm diabetic, and I'm wolfing down food, well, I'm probably going to eventually kill myself from the complications of diabetes, but if I choke on that ham sandwich that I'm wolfing down, then your priority there is the acute problem that I'm experiencing. Yes, they can both kill me, The diabetes might end up being the thing that kills me. But in terms of prioritizing my care at that point in time, in that moment, I look at what is acute. So I hope that will be helpful. Some of your potential nursing diagnoses are listed there. I don't think I need to comment on those. Let's move on to the section on communication, because I do recall, that this was an area that they wanted to see if you, in the role of the nurse, could select, what is the most therapeutic response. They wanted to see if you knew the rationale for certain therapeutic responses. So, as we look at this, I want you to first look at that section on goals there. And they make the point that we need to be listening and observing all of the patient's behavior, because they're going to be communicating with us verbally and non-verbally. Okay, so we want to try to understand the meaning of their verbal and non-verbal behavior. Okay, that's different from saying to the patient, I understand how you feel. Saying I understand how you feel is non-therapeutic. But our goal is to try to understand the meaning of the patient's behavior. We are wanting to facilitate or encourage that person to express feelings, verbalization of feelings. And we want to communicate through our empathy that we understand their experience is difficult, that we accept them, and then we want to have our interactions guided by our assessment of the patient that identifies problems or potential problems, mutually set goals, and then as we work our way through that interaction with the patient, that should be a client-centered, goal-directed interaction, that when we, there are certain things that ought to occur in the different stages of the relationship, and we'll talk about that in just a moment. But notice on there that most of communication is nonverbal, so it's important for us to note that if the verbal message that's being spoken by the patient is not congruent with the nonverbal behavior we can observe, that usually the nonverbal behavior is a more reliable for us to try to understand the meaning of their behavior. Okay, phases of the relationship. This is another important section. It's item number 3. It's at the very bottom of page 515. And there are certain nurse behaviors and patient behaviors that occur at these different stages. And there are certain tasks that need to be accomplished at the different stages of the therapeutic relationship, or sometimes referred to as the helping relationship. So, Kaplan uses a little bit different terminology. They call what I more often see as the introductory or the orientation phase, as they refer to it as the initiating phase. At this point, you are negotiating a contract with the patient about what the purpose of the relationship is, when you're going to meet with them, what the expectations are of the patient and the nurse, and that helps set the boundaries for the relationship. Now, also in that initial phase that Kaplan describes there, that is where you first mention termination. You let them know when the last visit will be. Okay? And so those are important things: setting a contract, discussing termination, discussing confidentiality. building trust and rapport. All of those are key in that beginning phase. As we move on to the working phase, this is where you are supporting and encouraging and facilitating that client to meet mutually agreed upon goals. So, again, we said that this interaction is client-centered and it's goal-directed. So we have a particular goal, and that requires typically for the client to develop some insight and awareness into the meaning of their behavior, maybe, things that trigger stress in their life, exploring the pros and cons of some different ways of coping with the stressors in their life so that they can be more successful. We know that one of the critical things that occurs during the working phase is resistance, because the patient is concerned about, they feel threatened because they're leaving they're venturing out into something that's unknown for them. So we expect a certain amount of resistance to occur. Terminating phase is where you summarize any progress or lack of progress toward those mutually identified goals. And it's also where you make any referrals that are needed for follow-up. It's where you bring some closure to that relationship, and you don't agree to continue to see the patient. If we flip over to page 516 for therapeutic responses, I want you to note that in the psychiatric setting, the instrument that you use to do your work is yourself. That's referred to therapeutic use of self. It's you're using all of your knowledge, your skills, your personality, your communication techniques to work one-on-one through that therapeutic interaction that is client-centered and goal-directed. Now, fortunately, I think this is great. They really limit the number of therapeutic responses and non-therapeutic responses that you need to be concerned about. There are many more if you pick up your Townsend book. So be sure and look at each of those. You need to understand, what is the rationale for using periods of silence, using a broad opening. There are questions on Kaplan that require you to know the rationale of therapeutic responses. If you want to get some more examples, you can easily go to Chapter 8 in Townsend. They give you some additional examples of these types of responses. But be sure that you know the difference between the therapeutic and the non-therapeutic. If we look on page 517, we'll see that they identify closed-ended questions as things to avoid in therapeutic communication. Now, they may be very useful to us when we do want to limit the amount of information we're getting from a patient, and we do want a yes or no response. But I can tell you that they consider those closed-ended questions, something that can be answered with a single word, as something that is not going to encourage more interaction with the patient. Do not give advice. Do not argue. Do not defend. Do not provide false reassurance. And very, 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 very important, and use a special color ink to mark this one, don't ask why questions. Those are classic kinds of things that appear on standardized nursing tests. Why questions tend to make the person defensive, or they'll try to respond with what they think you want to hear. So you do not want to select a why question. And we don't want to come across as being punitive or judgmental. Okay, some of the treatment modalities, if we flip over to page 518. These are all, I think, early on in the course we looked at each of these. There's some of them have their own chapter in Townsend. Some of the, if we talk about biologic treatments, that's referring to the psychotropic medications, the antidepressants, the antipsychotics. And there were a number of questions that related to medications. Fortunately, they were pretty basic, and we'll talk about some of the prototype drugs as we look at some of these sections. There is a brief section on ECT, and we'll look at that as well. When you see that psychoanalytical term there, they're referring back to the principles that were developed by Sigmund Freud, and so that relates to intrapsychic conflict, the id, the ego, the superego, our ego defense mechanisms, and a heavy focus on the nurse therapist recognizing that it's unconscious thoughts and emotions that actually motivate our behavior. Okay. Milieu therapy, that describes a therapeutic community where we should create a social environment with lots of structured activities, and every interaction ought to provide an opportunity for learning in the milieu. With group therapy, nurse generalists can lead some types of groups, but there are also specialized groups that require higher levels of training, like psychodrama. If you may recall Irving Yalom's curative factors of group therapy, where by having a group of people together who are dealing with similar problems, there's an economy of benefit where individuals can learn from one another. Behaviors can be role modeled. People can get hope. People can help others. Peer pressure can be applied to change behavior. And under family therapy, one of the important points there is that the problem usually is described by the family as being a problem with one member of the family, where that member is scapegoated. But the important basic principle to remember with family therapy is the problem is a family problem of how the family is interacting with one another, whether that is functional or dysfunctional. So it's a sick family rather than a sick member. The nurse therapist treats the whole family and points out problems with communication to try to build more open, flexible, supportive, loving kind of communication in the family. Activity therapy we refer to often as recreational therapy. This requires that patients come together and interact with one another very often. So we have to be careful about some activities that we choose. If it's playing basketball or a game of cards where there might be some competitive feelings that arise, then there may be some manic patients, or there may be some paranoid patients who may not be appropriate for that activity at that point in time. So we have to choose the activity based on the patient's functional ability at the time and what goals they need to be working on. Sometimes, early on in a hospitalization, the person might be involved in some activity therapy, one-on-one with the nurse or the activity therapist. Play therapy, I don't think we talked about this in any detail. You may have read about it in Townsend, but I did see quite a number of questions that were related to children. And so pay particular attention to this section. We know that children at a very young age don't have the verbal skills to express themselves the way an adult would. So often they can express themselves through art or play. There's one technique called a kinetic family drawing where you give the child who's old enough to draw a recognizable human figure, they may be 6 or 7 years old, you give them paper, you give them a variety of colored crayons, you ask them to draw a picture of all the members of their family and draw everybody doing something. And that, after they finish the drawing, then you ask them, well, okay, who is this person over here by themselves? Who is this scary-looking person over here? It's a way to get at the feelings and the conflicts that are in the family through the child's artwork when they may not have the vocabulary to describe all of that to you. And finally, behavior therapy. They mention operant conditioning. We use praise and other types of rewards to provide positive reinforcement to increase the likelihood of behavior is going to occur. And remember, negative reinforcement increases the likelihood of some behavior occurring to avoid something unpleasant. And there are definitions for those in Townsend if you need to read back over them for a little more clarity. Any questions about treatment modalities? Okay, let's move on to the next chapter is Means of Coping, and it focuses on anxiety. This is on page 519. And I would take the time to have a very clear understanding of those descriptions of mild, moderate, severe, and panic levels of anxiety. You need to be able to identify what the assessment findings are that are characteristic of high levels of anxiety, and they list those there for you. Flipping on over to page 520, I think, those initial assessment findings are pretty obvious to us, palpitations, nausea, vomiting. But at the top of page 520, they look at some of the cognitive or intellectual findings for high levels of anxiety. So be sure that you are familiar with those. It's not necessary to memorize them as long as you're able to recognize them. Okay, ego defense mechanisms. Let's flip on over to that section because you do need to be able to recognize those, and they're listed on page 522. Now, if you need additional examples of these ego defense mechanisms, you have several that are on page 20 in Townsend. Some of the more common ones I see tested are denial, rationalization, reaction formation. But you will be well served to be able to recognize each of those. Because if you're not tested on all, you're not going to be tested on all of those on Kaplan. But you'll eventually be tested on them on one of the several standardized tests you'll need to take before you get licensed. So I would look through those, look at additional examples in Townsend if you're unclear about any of those. But again, there are some that tend to be tested more than others, like denial, rationalization, reaction formation. Okay, nursing management of anxiety. If we go back to page 520, they talk about medications. We'll look at some anti-anxiety agents. Look at your goals there for nursing management at the very bottom of page 520. That's a repeat of what we've seen before. That just reinforces a message from the previous chapter. It concerns me a little bit on page 521 that they put the eating disorders in with the anxiety disorders. I think Kaplan does a few things in this content that's a little sloppy, but if, really no harm, no foul, just recognize that, they have dropped anorexia nervosa and bulimia nervosa in with the anxiety disorders, and that is not what the DSM does. But the main thing that you need to focus on is what are the symptoms that are associated with these disorders, because there's quite a bit of information that required you to recognize, what can the nurse assess for a particular diagnosis. Okay. And they also, in this chart on page 521, they give you some tips about some behaviors that you can use that are supportive or helpful to the patient. And just as an example, we don't have time to go through all of them, but let's look under bulimia. Okay. The person may be of normal weight, okay, or slightly overweight with bulimia nervosa. And one of the first line of treatment, first line therapy for psychotropic drugs treating bulimia nervosa is the SSRI. Now, we did not talk about conversion disorder, and actually, if you look at the very last item on page 521, conversion disorder is a somatoform disorder, but let me call your attention to that one, because with conversion disorder, the person has some loss of sensory or motor function. Okay, now think about those two words. They have some loss of sensory or motor functioning. An example of some sensory loss is they may start experiencing the world as a blind person would, telling you they cannot see. Or an example of a motor loss, they may lose the function of an arm or a leg. Okay? And the key component here is there is no underlying medical problem that explains this sensory or motor loss. It's called a functional loss, not an organic loss, because it is based in some kind of psychological trauma. And often the loss is highly symbolic of the trauma the person experienced. And I'll tell you, it's not that uncommon to see conversion reactions. Now some of these other disorders, some of the dissociative disorders, like what we used to call multiple personality disorder, which is now called dissociative identity disorder, extraordinarily rare. Conversion disorder, though, is I would not call rare. We see it in a lot of nursing settings. It's more common among people who are a little unsophisticated, people who tend to be highly psychologically sophisticated and well-educated or less vulnerable to developing conversion reactions. But children develop them, adults develop them. They may, like I said, tell you they suddenly became blind, or they suddenly became unable to walk. And often they have seen or heard something very traumatic, experienced something very traumatic, and this loss is symbolic of what the trauma experience was. So if they saw something horrific, they may have this case of hysterical blindness. And I just read the ham sandwich comment about this. Sorry, I got distracted. But so this person becomes has this sudden loss, and in about a third of the people with conversion reaction, they have a phenomena called labelle indifference. And that means that they don't seem concerned about this loss. This person's just become suddenly blind, and they don't act as upset as somebody should. Now, they are not malingering. They are not faking an illness. That's a whole separate category, okay? They are truly, genuinely experiencing this loss. One of the quirks of something like conversion disorder, like hysterical blindness, would be that the person is experiencing the world as if they were blind, but they would be able to walk through a room without bumping into furniture. So it's illogical, it's irrational, but it's genuine. It's not faking, it's not malingering. This person with supportive care tends to recover their function over time. If they re-experience the trauma, they tend to have the same kind of loss in the future. And let me tell you, I have been in settings where in an emergency department, a physician might see someone that they suspected conversion disorder with, and in front of the patient, he'd turn to the nurse and say, give 2 cc's of 0.9% sodium chloride stat and give the whole dose. Well, that's saline water. That's given a placebo, okay? And sometimes there's a spontaneous recovery when people are given treatments like that. But let me caution you, for testing purposes, don't ever use deception around the patient. The answer that you get credit for does not include deceiving or tricking the patient. So giving that placebo would not be an option that you'd get credit for. So keep that in mind. They refer to secondary gain at the very bottom of that page. You know, the individual who has this loss is the secondary gain simply means that they are able to maybe avoid some responsibility that was weighing heavily upon them, get some special attention, avoid having to do something. So there is a reason, an unconscious reason why this symptom has been produced. Okay, moving on. Let's see. We talked about the defense mechanisms. We talked about the anxiety disorders and the ones that really aren't anxiety disorders, but we're not going to worry about it for the purposes of this test because it's not going to affect you. So we did the ego defense mechanisms. Okay, let's look at the top of page 523 where there's some nursing interventions. And I'm going to press ahead. You can take a break when you need to, but we've got a lot of ground to cover. I would take some time looking at these nursing interventions because I'm telling you there are a lot of, and I can say this about any standardized test, but there are a lot of times where the answer you get credit for is something the nurse can do. You know, you want to look for, don't look for putting it off on, wait till the doctor comes in, talk to the doctor about that. But if they give you a good option of how the nurse can directly address that problem and intervene at this point in time with something that's appropriate, that tends to be the answer you get credit for. So look for something the nurse can do to address the problem. And we've already mentioned before, from the very top of page 523, that you must be able to assess the level of anxiety the patient's at. Okay. Keeping the environment stimulation as low as possible. We know that if someone is at a severe to panic level of anxiety, we want to get them out of a chaotic environment to a quiet, calming place where we remain with them. And if a person is manic, we know that we want them to be in an environment of low stimulation. Let's look at assisting the patient to cope more effectively. This is a whole process. We need to acknowledge the person's experience of high anxiety. That goes back to that tip that's always so helpful. There's opportunity to acknowledge the feeling they're experiencing. You want to do that. So we acknowledge that, again, remaining with extremely anxious person. There may be some things that can reduce anxiety if it's not too high. Just having an outlet for physical tension can help bring relaxation. We've talked about that. Helping that person evaluate, what their own strengths and weaknesses are. We've talked about that. And developing, what triggers their anxiety, recognizing what triggers it, learning new ways of coping. And some of the places that they learn those interpersonal skills can be one-to-one interaction with a nurse, or it can be by participating in a therapeutic group where behaviors are modeled by their peers. And then finally, I want to make a comment about this last intervention in this table where it says, maintain accepting and helpful attitude toward the patient. I expect all of you attempt to do that with all of your interactions with patients. And I also expect that you've observed lots of professionals who, and I've been guilty of this myself, who are not communicating with patients in a way that is accepting and helpful. Okay. Sometimes we know that we see burned out staff who are sarcastic, who are irritable. And so you're going to see this kind of thing tested. You're going to see, is the nurse interacting with the patient in a way that's accepting, helpful, not sarcastic, not irritable. And that seems like it would be fairly obvious to be able to spot. But, you also don't want to be judgmental or punitive, critical, giving advice, those kinds of things. Again, they say in that last one, acknowledge the patient's distress. Again, acknowledge feelings, and acknowledge feelings. Okay, very bottom of this page is anti-anxiety agent. And you've got some prototype drugs that we definitely want to mention here. Whenever you see Librium, you ought to think detox and alcohol withdrawal syndrome. These are all, if you look at these benzodiazepines that are on this page, we know they have a depressant effect on the central nervous system. And look at that toxic buildup in the elderly. Because elderly persons often have diminished hepatic and renal functioning, the drugs, it takes longer for them to be metabolized and excreted, so you have toxic accumulation. So keep that in mind. And look at tolerance and cross-tolerance. If a person's had a bad reaction to one of the benzodiazepines in the past, it's likely that they might have a similar reaction to another drug in that category. So keep that in mind. Alcohol is going to greatly potentiate the CNS depressant effect. This person is going to be a fall risk. And I would say Xanax might be my prototype drug. I think it would be worthwhile, reading, going back and reviewing all of your information on Xanax. We know that because this is a CNS depressant, it can, cause depressed mood in some persons who are taking it. Can cause certainly drowsiness and dizziness. Some of the more common, less serious side effects you see are nausea and vomiting can occur with Xanax. So I would take a little bit of time and go back and look in some detail at all of my prototype drugs. And Xanax would be the one I would look at for benzodiazepines. Librium for alcohol detox. But if you look at the suffix on these anxiolytic drugs, many of them you'll recognize: diazepam, alprazolam, clonazepam, lorazepam. Gosh, I haven't seen Serax used in like forever, but it's listed on there. I don't think you need to be concerned about Serax. If we flip over, we can look at the non-benzodiazepine agents. Many psychiatric nurse practitioners and many psychiatrists are very concerned about prescribing benzodiazepines. Some of them don't want to prescribe them and look for alternatives. Buspar, buspirone, is a non-benzodiazepine. Be sure you look at the side effects for Buspar. Be sure that you know that it may take 3 weeks before you experience the maximum benefits of it. And another safe one is hydroxyzine or Vistaril, also known as Atarax. Sometimes when people want some benzodiazepines to help them sleep, the doctor may prescribe 25 milligrams of Vistaril, and if you're not asleep in 30 minutes, take 25 more. But if you'll notice over there, Vistaril does not produce dependence, tolerance, or intoxication. So it would be considered a safe alternative to a benzodiazepine. Pay attention to your herbals. I'm seeing more and more test questions about over-the-counter drugs and herbals and the possible nursing or the interactions that might occur. Whoops. Let me find my slides. We talked about the anti-anxiety agents. There you see the Xanax, which is the prototype drug for the benzodiazepines. They often come in these bars. So be sure and know what the risks are of these drugs and what some of the common side effects are. And, there's not a lot of them in this section on Kaplan, which is a great help. Okay, the next chapter is situational crises. And one of the things I really like about Kaplan in this chapter is they simplify it. I think their presentation of it is a little better than Townsend because they give you a nice, concise summary. And we know a crisis is a period where a person's usual coping mechanisms are not going to be adequate. Notice on page 525 that we're talking about a relatively short period of time, and the time frame that Kaplan uses is 4 to 6 weeks. There is the opportunity. Now, our number one goal as the nurse is going to be to get that person back to their pre-crisis level of functioning. But if you look at item number 3, the top of that page, it's important to note that there's always that opportunity for growth and development during a crisis, where the person can acquire new coping skills. And they simplify the types of crises. They use developmental, as a person transitions from one stage of development to another, they may not make that adjustment smoothly or in a healthy way. Those would represent a developmental crisis. Situational crisis, I'm not going to complicate things by introducing some more terms that Townsend uses, so let's just, for the purpose of this particular exam, let's just look at the way Kaplan defines situational crises. Some crisis, the loss of a home, loss of a job, some natural disaster. And, I have to, let me take that back. They actually put loss of a job under a category of threats to self-concept. That's not a category that I've seen before, but I don't. There's nothing that you need to be concerned about in Kaplan that requires that you memorize those lists at the bottom of page 525. It's just recognizing that sometimes people will experience crises as they transition from one developmental stage to another. Sometimes, some loss of self-esteem can cause a crisis, and there are a variety of different things that can contribute to that. Okay, more importantly, I think what I would focus your attention on, if we flip over to page 526, they describe what is called the crisis intervention process. It is streamlined. It is a brief kind of highly structured, more directive kind of interaction from the nurse. It's something that's accomplished in a relatively short period of time. It focuses on a particular crisis that the person is overwhelmed by, and it is, you recognize assessment, I'm sure, some of the same elements we've looked at before. What are the person's internal strengths? What are their external supports? And then we want to help them through more guidance and direction to look at some potential solutions to their problem, explore the alternatives. And the focus is on that limited problem. You might rehearse with the person how to talk with others, to solve their problem. And then finally, the term anticipatory guidance is used because if you're helping this person acquire new skills, you're teaching them skills that they'll be able to use if the crisis recurs. So, some tips to remember regarding your nursing management. We've talked about your interactions being goal-directed. These are finely focused, and you're really honing in on one specific goal and functioning in the here and now. So you're not going back and looking at a lot of things that occurred early in the life of the person, but you're focusing on solutions to their problem in the here and now. Another important point at the very bottom there, you're helping that person to identify support systems and mobilize those support systems. And finally, up at the top of page 527, you might need to make a whole variety of referrals. Sometimes a person may need financial assistance. They may need further counseling. If they've lost a job, they may need vocational training. I wouldn't spend a whole lot of time on table 15.9 on page 527. I certainly wouldn't memorize any of those stages. I would look at rape trauma and just read through, if we look in the middle section on rape trauma there are going to be specific emergency room protocols to follow regarding the collection of clothing and samples as evidence. And first we're going to focus on what has the most life-threatening potential. Are there any physical injuries that need to be addressed? And then we may end up making referrals for the person to have counseling. Okay, let's flip on over. The next section on page 528 deals with grief. And And I would just call to your attention that we deal with patients who are experiencing a whole variety of different kind of losses, and I want you to recognize the types of losses that are listed in item number 2, because that can be the loss of some kind of function due to a medical illness. It can be some alteration, some in their appearance that represents a loss because of having to have some surgery. And I tell you, the thing that I believe is most important in this section is actually on page 529, where they talk about managing the dying patient. See if I can get over to that slide. So let's look on page 529. Whoops, I jumped ahead. There we go. Just a few points to make about this. And I believe you may have discussed, I don't know if you've gotten to death and dying yet in your Gero class, but the initial problem that's dealt with in that chart is how we as caregiver have to examine our own feelings. And they say that the nurse as caregiver or a family caregiver may have concerns about their own mortality and so on. So the interventions that they recommend for us over there are that self-reflection, the introspection that we need to practice as a caregiver, acknowledging our own unresolved issues that we have about death and dying. And then they ask that we focus on the more positive aspects of care, relieving the patient's pain, providing comfort measures. Sometimes those are non-pharmacological measures, or relieving anxiety. Another important point that they make in this section is keep the communication open so that the patient feels comfortable expressing any feeling to you. The patient may have some misconceptions about their illness and some things that we can clarify with accurate information. And we should be guided by what the patient says to us. Our focus should be on what's most important to that patient. We should not be setting the course for the conversation so much because we think the patient needs to talk about X, Y, and Z. Let the patient decide what's important for them at that particular time. And they make a very important point here in the middle of that page. They say respect denial rather than giving excessive information. Okay? Yes, we need to answer questions. We need to clarify misconceptions. But denial can serve a very healthy purpose in the dying person's process of dying, that we don't want to overwhelm them if they're not ready to hear certain information. We recognize that denial is a stage of death and dying, and we need to support the person as they're working through that stage by not overwhelming them with too much information. Okay, I think that's all the comments I want to make about that. Let's move on to the chapter on depression. And they make the point on page 531 that you've got different types of depressive disorders. The most severe level is a major depressive disorder, and there are a variety of different types. This is the intensity, the duration, the scope of the depression will be greater than dysthymic disorder. Remember that dysthymic disorder is a milder, more chronic form of the illness where the person feels depressed more days than not for at least 2 years for the adult, 1 year for a child. Don't worry about depressive disorder not otherwise specified. I don't believe that you need to be concerned about that. Plus, that's old information that's changing with DSM-5. Another important point there under item number 4, we know that older adults, particularly older males, are at high risk for suicide. And this section at the very bottom helps us be able to assess for the signs of depression. You will need to know on Kaplan what are the assessment findings for the major mental disorders: anxiety, depression, schizophrenia. Okay. So, look at item number 2 under assessment, very bottom of the page. Those are things I believe all of y'all recognize. You know, disturbances in sleep and appetite are hallmarks of depression. And those disturbances in sleep can be the inability to fall asleep, remain asleep, or it can be hypersomnia, staying in bed all day. And the appetite changes can be anorexia or overeating. So recognize what your assessment data is for your major disorders. And if we flip over to page 532, constipation can be a sign of depression. All the body functions slow down. Look at your cognitive symptoms. We've seen this in test items in the course. You know, the inability to concentrate, decreased attention span. Think of the depressed persons you've interacted with in the clinical setting this term. And I bet you can think of people that demonstrate most of these symptoms. So don't overlook your cognitive symptoms. Okay? And we always assess suicide potential. You know, we want to know, are the thoughts passive suicidal thoughts? You know, it'd just be better if I didn't wake up in the morning. Are they, have they developed a plan, and do they have a means to carry out the plan? Is there a history of suicidal gestures or suicide attempts? What was used? You know, did the person take pills? What did they do to try to harm themselves in the past? Will they contract for safety? So all of those important. Always assess for suicide potential. And there's a very important box there. We've talked about this more than once in class, but I would call your attention to that. This is a huge safety issue, the behavioral clues of impending suicide. The person becomes more energetic, and particularly in that period, 10 to 14 days after starting on an antidepressant, they may be at greater risk for suicide. So be sure that you keep that in mind. We have to provide an environment in an inpatient setting that is free of contraband, those things that are breakable or that a person can harm themselves with, that are sharp. Now, I would look at, on page 533, there's certainly some really good tips for nursing management. These are all things that you may have practiced in the clinical setting, but I would read that table on page 533 very, very carefully, because it's going to address ways that we can be supportive to the depressed patients, ways that we can keep them safe. That's a very important table on page 533. And then finally, at the bottom of that page, they give you a nice little summary of what to do for ECT. We know what the person is going to be, have nothing by mouth after midnight, okay? You know, so there's certain safety issues that are critical and essential for you to remember. So be sure that you read through those few points about ECT. I think you'll recognize them for what you, based on how y'all answered questions on our test. You seem to know this fairly well, but each one of those points is important under ECT. Okay. And antidepressants. Again, let's think in terms of what are the prototype drugs for these major categories. Okay, they on page 534, Kaplan lists the MAO inhibitors first. You're more likely to see Parnate or Nardil as examples. Remember, that's Parnate or Nardil. And look again at your foods that you're supposed to avoid. Most foods do have some tyramine in them. Some foods are higher. Things that are aged, preserved, pickled tend to have higher levels of tyramine. Things that older food, overripe avocados, overripe bananas, they have higher levels of tyramine. But some things that should jump out at you are the aged cheese, the organ meats, the things that have yeast, things that are fermented. You want to avoid high levels of caffeine. You want to avoid stimulant drugs. And there has to be a washout period. You know, if someone's on SSRIs, they have to be off those a couple of weeks before you start them on a drug like Parnate or Nardil. They mention sunblock on there because it does increase photosensitivity. Okay, so be sure that you look at all of your safety issues related to Nardil and Parnate. The next category are the tricyclics, and tricyclic antidepressants are often referred to as TCAs. These were an older category of drugs. They caused lots of anticholinergic side effects. You know what those are. They're listed in the side effects here. Be sure that you recognize all of your anticholinergic side effects. But these drugs tend to boost epinephrine. The suicide risk is high because it's fairly easy to take a lethal overdose. Many times because one of the side effects of the TCA drugs, and the prototype is Elavil, one of the side effects is sedation, so that can be used to your benefit by taking the whole dose at bedtime. If you have a dry mouth, you can suggest, practical sorts of things to the patient, like chewing sugarless gum or candy. These drugs take a little longer than the newer drugs for you to experience the most benefit, and a drug like Elavil can be cardiac toxic, so it may not be appropriate for older adults. But I would look particularly at Elavil for my prototype drug. It would be really nice if you could recognize some of these other drugs, because you're probably going to see them on some standardized test. Tofranil is used also to treat enuresis. Sinequan's used very often to help people sleep. Pamelor is used kind of like Cymbalta. If people have peripheral neuropathy, that drug is a nice cheap version of Cymbalta. Cymbalta duloxetine is an SNRI that's often prescribed for diabetic peripheral neuropathy. But if people can't afford that expensive drug, Pamelor is on the $4 list of drugs that you can get at Walmart for a 30-day supply for $4. And a lot of the tricyclic drugs have been used in combination with other pain drugs because they have a synergistic effect and they help with chronic pain syndrome. But Elavil would be my prototype. And for the next category, the selective serotonin reuptake inhibitors, Prozac or fluoxetine would be my prototype drug. And it has some mildly bothersome side effects, but you don't see any really serious side effects. It does have a mild stimulant effect, so it can interfere with people's sleep. They need to take it in the morning. It takes a few weeks for it to work well, and notice on there it can decrease appetite. Now, the next category they have are heterocyclics, and I don't know why they put Wellbutrin in that category. This is another example, I think, of them being sloppy. That's an SNRI, but don't be concerned about that. That should not be an issue for you. Desiril, yes, I would put it in that category. You can have some anticholinergic effects. When they talk about may require gradual reduction before stopping, they're just talking about a good general principle of tapering off the meds to prevent any withdrawal syndrome of restlessness or headache that you might get if you just stopped cold turkey. Herbals, you need to be able to recognize that St. John's wort is grown all over the world now. It's cultivated for sale, and it's often used to as an over-the-counter way to treat depression. So you need to know that there are lots of contraindications with it. It doesn't mix with MAO inhibitors. You can have a serotonin syndrome with a extremely high fever if you take it with an SSRI. So be sure to look at those cautions about herbals. Okay, moving on to bipolar disorder on page 535. Again, something that I've noticed that Kaplan places some importance on, and it makes sense. It's a first part of the nursing process, is that you need to be able to identify what the classic signs and symptoms are of each of the major mental disorders. So you've got a nice list there that you should recognize for mania. Okay. Now, typically we see mania lasting more often a few days. People in the most extreme form of the illness that have what is called a delirious mania can have a mania that's sustained for several months, and that person is at risk to die from exhaustion. That's someone who might be referred for ECT if they have a mania that lasts for several months. Okay, let's flip over to page 536 and look at the characteristics of the depression that's associated with bipolar disorder. Okay, you should recognize all of those symptoms. We see the appetite disturbance, we see sleep disturbance. Those should be very familiar to you. Let's look at some of the causes of bipolar disorder. They break them down into psychodynamic, which would be more Freudian-based, and it's believed that the grandiosity is a defense mechanism against low self-esteem. Is someone trying to speak? Okay. Let's look under the predisposing factors. We certainly know that there's a high degree of heritability with bipolar disorder. If you have a first-degree relative who had a bipolar disorder, you're much more vulnerable than someone in the general population. Excessive amounts of norepinephrine may be involved in manic episodes. And there does tend to be high levels of substance abuse disorder where people, they have in parentheses there, they're trying to self-medicate. They're trying to relieve their symptoms with alcohol or other drugs. Okay, now they get into some of the problems that we can observe. And look at unable to meet physical needs. So what are some very practical ways that, we need to hydrate and we need to nourish this person who's not going to slow down enough to eat or sleep? So, physical exhaustion is also another concern. This person is going to be very intrusive, very demanding very often. We often have to remove them from that overstimulating environment, not place them in activities with other patients where they're going to be involved in competition. And at the very top of page 537, they talk about that. Avoiding that overstimulation, avoiding competitive situations, removing the manic person to a quiet area. Distraction and redirection can be helpful techniques. Activities that don't require long, sustained attention span. They give you some very practical tips and techniques to manage manic behavior. Even, one that we've talked about before, finger sandwiches, they recommend cupcakes. As something, they can literally eat on the run. But I would look at those nursing management techniques for bipolar disorder. Those look extremely helpful. Now, moving on, I want to look at the medications for bipolar disorder. Y'all seem to have a pretty good understanding about lithium. There's a whole variety of forms of lithium. There's lithane, there's lithobid. You look for that prefix, LITH, and look at some of your common side effects. Now these are common; they don't represent toxicity, but the fine hand tremor is common. Okay, I think your signs of intoxication that they've got listed here will be adequate for your preparation for Kaplan. They go into a little bit more detail in Townsend, but and if you look at the target levels are a little different in Kaplan than they are in Townsend. So focus in on that. Under the nursing considerations, they're just a little slightly different. The same general range, but pay attention to what Kaplan has in there. Now, one of the anticonvulsants that was initially used as adjunct therapy with lithium, one of them is carbamazepine, that's Tegretol. And notice on there you can have some blood abnormalities when you take Tegretol over time. So you have to do a CBC when the patient is on Tegretol to monitor for some of those side effects. And then I refer to Depakote as valproic acid. I don't use that term. You may see it like the valproic acid levels being drawn on the patient. Again, you have to. There is a narrow therapeutic window for lithium and for Depakote. So there are serum blood tests that can be used for that. Let's look at the top of page 539 because there's some additional things about lithium that I think you need to be aware of. If the person has some significant cardiovascular disease, they're not going to be a good candidate. We know that lithium can cause abnormal development of the heart in utero. And thyroid and kidney functioning have to be monitored when the person's on lithium. They keep the signs of lithium toxicity pretty simple there. Now, notice they say tremor, but I want to call to your attention, a fine tremor is normal. It's a coarse tremor that's associated. You have a coarsening or an increase in the tremor that's associated with toxicity. And if you give this person a diuretic, that can increase the level of toxicity. Okay, let's move on to altered thought processes. This is on page 541. And I'm not going to go through each of these symptoms, but I'm going to tell you that you do need to recognize, of course, we know paranoia is a very prominent sign of schizophrenia. But you need to recognize all of these signs that the nurse can assess for that are listed here. Now, I do want to call your attention on page 542 to something I noticed there. And Kaplan talks about something called conditions that can predispose someone from withdrawing from, or predispose them to withdrawing from reality. And I think we recognize these. If we're talking about altered thought processes, certainly there's what I initially think of is a thought disorder like schizophrenia. But they say that other things can cause the person to withdraw from reality. Certainly dementia, like dementia of the Alzheimer's type. An acute psychosis can result from some drug intoxication. Some kind of metabolic disturbance that could cause delirium. They even mention, what I think they're referring to very dysfunctional family dynamics in that item, and then schizophrenia. Now, I don't think you need to memorize those types of schizophrenia that are listed there, but certainly know what some of the common presenting symptoms are for schizophrenia. I would not worry about memorizing the different types. But as we move on to nursing management, the nursing management is on page 543. We see something that we recognize there. So that the person is not overwhelmed, we decrease stimuli. And we present reality. When it says validate reality, we're presenting reality in a matter-of-fact way as we experience it. We're not argumentative with the patient. But we don't want to do things that are going to reinforce a hallucination. We have to assess. We have to present reality. We can certainly acknowledge that the feelings are distressing to the patient. But we don't want to call a lot of attention to the hallucination because that's going to make it more likely to be repeated. They give you a general approach to working with this person with altered thought processes. Let's flip over to page 544. Now, they make the point here under item number 3 at the top of page 544 that, if the patient is severely regressed as somebody in a catatonic stupor, that my priority there is going to be, basic physical needs, hydration, nutrition, hygiene, those kinds of things. Okay, we can continue on to the section on antipsychotics. Certainly, now, they've got some old drugs here. The older, what were called typical antipsychotics would have as a prototype drug Haldol. You should be able to recognize if you see Prolixin, that is also an older typical antipsychotic. Now, I'm going to mention some of the other older ones that you may need to be able to associate in that category along with Haldol and Prolixin. Drugs like Mellaril, Stelazine, and Navane, they're all old typical antipsychotics. And you have all of those, you have a pretty high incidence of those extrapyramidal side effects. The Parkinsonian kind of symptoms, the dystonias, and then you can have long-term side effects of tardive dyskinesia, and you can have those acute life-threatening side effects of neuroleptic malignant syndrome. that are more common with these old typical antipsychotics. Okay. Trilofan is another older one. Thorazine is an older one. So we don't get to the atypicals until we get to Risperdal, Seroquel, Geodon, and so on. Clozaril has been identified as the prototype drug of these atypicals, and I would read everything. I would go back and read everything that Townsend has about Clozaril. We know that, and I think, we're pretty good on this last test in terms of, monitoring the person for flu-like symptoms, fever, malaise, body aches, those kinds of things. Monitoring their CBC for a dip in the white blood cell count, holding the drug if the white blood cell count gets below 3,500. And you're trying to prevent a lethal agranulocytosis, a type of blood dysplasia. Okay, now you can develop EPS and you can develop tardive dyskinesia and neuroleptic malignant syndrome with these new atypicals. It's not as common. They are more specific in the areas of the brain that they act on, so you tend to have fewer abnormal involuntary movement kind of symptoms. But if you're the person who has them, it's 100% for you. Okay, look at your side effects. They have a nice little summary of side effects. Okay, moving on. I know we are rapidly running out of time. I won't spend a lot of time talking about this section, but I will tell you those nursing interventions are extremely helpful. You look at managing a patient who is very withdrawn, making eye contact when you greet them, accepting their behavior and having a matter-of-fact attitude towards their behavior. They tell you how to react to hallucinations. They tell you how to react in the next table to the person who's suspicious. Keeping appointments so they know you are reliable, that this is the person who will test you. How to react to that person who's delusional. Not arguing with them. Connecting feelings with the delusion. And then finally, how to manage aggressive and violent behavior. You're using that non-threatening physical approach in your body language. For violence, you want to intervene early and try to de-escalate the situation. Okay, the next chapter focuses on, it's an interesting title. They call it social interactions, and then they talk about personality disorders, alcohol, and other drug abuse, which I found really interesting. But for manipulative behavior, we talked about this Friday when we talked about the antisocial personality disorder and the borderline personality disorder. Let's flip over to page 550 because they say that, you have to set limits on inappropriate behavior. You have to be consistent and still maintain a non-judgmental attitude in your interaction so that you're not being sarcastic with the patient. They talk about, when you're given your rationale for why there are certain rules on the units, be brief. Don't try to give elaborate discussions. And often we're going about our business, doing our work on a unit, a psychiatric unit, and sometimes we just get blindsided by somebody who they slip in some manipulation and we don't catch it right away because we have to be constantly on alert for excessive compliments, attempts to get personal with us, or need our help, or be very needy. These can all be elements of manipulation. They talk about intoxication. They use a little different measurement. We said 100 to 200 deciliters. They're They're using it in percentages there, so the decimal place is a little different, so pay attention to that. I think you know how to assess for alcohol intoxication from your last test. On page 551, they do talk about antabuse, disulfiram. Be sure that you read about that and the safety issues that are associated with that. And they talk about Wernicke's and Korsakoff's at the top of page 552 and what the treatment is for that, about the thiamine replacement. Again, those are long-term chronic problems. The nursing management section is very important. I won't read that to you, but there are lots of safety issues that appear in this section. Be sure you pay particular attention to the safety issues. And before we move on to this chapter on abuse, there is one last chart on page 554. There are similar charts in Townsend. You know, if you're comfortable with this material, the only reason to go to Townsend would be to get some additional examples that might reinforce your understanding. But they have this as the non-alcoholic substance abuse. So you have alcohol and then you have other drugs. And we have looked at the symptoms of abuse and withdrawal. You need to be able to recognize those. So that is a review. I think the one thing you may want to pay particular attention to are your nursing considerations there, because they talk about giving drugs like Narcan to reverse the effects of opiates, reducing sensory stimuli for people who are under the effects of hallucinogenic drugs. So those nursing considerations can be very helpful. And I believe this final section here, as we wrap things up, is the chapter on abuse. It begins on page 555. Now, they start out by defining child abuse as a whole variety of different types of abuse that I think you'll all recognize. They make an important point here under item number 2. I don't recall at any time having discussed this with you, but I want to call this to your attention. If you haven't run across this information already yet in some other course, it's extremely important that you remember that children who are at high risk are often, children who are born prematurely. They may have physical or they may have mental problems. They may be the child of a teenage parent. Okay, there's your assessment information, and it focuses on certain patterns of injury that might be typical of how children are abused. Like certain types of fractures, certain types of patterns of burns. Poor hygiene, poor nutrition. Now, I want to point out something to you that often catches students off guard, but if we look at the nursing management section on page 555, we see a principle that we've talked about before, following Maslow's hierarchy of needs, provide for physical needs first. So that's how we're prioritizing our care. But the thing that I want to point out to you is a little farther down the page. Yes, we know there's mandatory reporting. If you have a reasonable, and pay attention to that term, reasonable belief that abuse has occurred. But the thing I want to point out to you is item number 3, because this seems to confuse students sometimes. We take a non-judgmental approach towards the patient. in the parents. I should say parents, pardon me. And yes, at some point you may want to separate the abused person from their caregiver, but initially you take that non-judgmental helping approach, even when there's that suspicion that there may have been some child abuse. So we want to be able to assess those parents and their responses, and we know if we come across as judgmental to them, they're going to shut down. Often, we can role model appropriate behavior in front of parents. They may have no parenting skills. Another important safety issue for children is teaching parents normal growth and development so that they have realistic expectations. Okay, flipping over to page 556, they talk about elder abuse. And you need to know that taking advantage of people financially is another form of abuse. And it's being taken seriously and investigated now by Adult Protective Services in the state of Georgia. Look at your nursing management. We see those principles: safety, 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 and how to prioritize our care. Mandatory reporting. So I would look through, each of these sections. You have additional sections on sexual abuse. We know the victims come from any socioeconomic background. Look at your nursing management on page 557. When you're dealing with such a sensitive issue, it's going to be very important, again, to establish that trusting relationship. You have some really good questions that are offered in Townsend. I'm not sure, I don't have any specific memory, and I can't tell you absolutely that you're going to need to know how to phrase those questions for Kaplan, but at some point I know that you will be tested on some standardized nursing test where they're going to ask you, how do you respond to the survivor of a sexual assault? And on that handout I provided you with, there's some specific ways to address the survivor. And it may not be intuitive to you to use some of those types of therapeutic responses, but they talk about them in Townsend, and I would encourage you to look at those. Okay. Let's flip over one last thing under nursing management on page 558. They talk about providing privacy. You may need to separate the perpetrator from the client. And you can do that with making a matter-of-fact type of statement. This is part of the exam that's always done in private. And one priority is going to be, and this is very important for you to remember, when you're dealing with someone who is the survivor of domestic abuse, develop a safety plan. When you're in private with that individual, help them to develop a way, identify a shelter, or develop a way of escape and a safety plan. And when we're referring client to resources, we may not want to send them back out to their perpetrator with a handful of pamphlets. We have to be a little more discreet in how we provide information. But there are laws that do require mandatory reporting if we have a reasonable suspicion that someone has been abused. Okay, that covers that content. And again, I think the most important thing that you can do is be sure that you read that whole question completely and carefully. Take the time to do that. It'll end up saving you time in the long run. And don't think about what the answer is until you have read the whole question. Do you have any particular concerns going into the test? You have my word that I will be generous on the curve, because this This is not intended to be harmful to anyone in the class. And thank you, Yasmin, I appreciate that. It's something that I want you to do well. I think you can be very successful on it, and I will certainly provide you with a nice little bump that I think will be helpful to everybody. So let me look at the results. And if you have any last-minute concerns, you can always text me. Thank you. Bye-bye.